As we continue looking at injuries in the body, we turn our attention now to the upper extremity. This is really the meat and potatoes of the course, where before we looked at injuries to the head and face. Now we're looking up at the upper extremity. We'll then move to the lower extremity and the core and learning module 4. In this section of the upper extremity, we're going to look at the shoulder and upper arm and specific injuries in these areas. There are many mechanisms of injury that are very similar regardless of which area of the upper extremity is injured. Some injuries require immediate referral to emergency medical services, whereas others do not. When we look at the shoulder and upper arm, some athletes think the shoulder is only composed of a ball and socket joint, which is typically referred to as the glenohumeral joint. They are correct that the glenohumeral joint is part of the shoulder. However, the shoulder is a lot more complex than that. It is also composed of the humerus, clavicle, and scapula bones, as well as the scapulothoracic, sternoclavicular, and acromioclavicular joints. The first injury that we will look at are fractures. Typically, fractures occur to the clavicle and humerus, with the most common fractures occurring to the clavicle. When we look at fractures, bones such as the clavicle and the humerus change shape, and at these areas of changing shape, they are the weakest. Therefore, the clavicle fractures most often occur at the middle 1/3 of the bone. The humerus usually fractures below the head of the humerus at the proximal end or close end of the bone. When we look at specific mechanisms for fractures, typically we look at someone falling on an outstretched arm. Another mechanism of injury for a clavicle and humerus fracture is a direct blow to the bone or the tip of the shoulder. Typically, we see transverse fractures of the humerus. These are very common. The humerus can sustain also a spiral fracture if the hand is placed on a firm surface and twisted, or it can also have a compression fracture, and they can occur when the athlete's palm lands on the ground with the elbow extended. Typical signs and symptoms include pain, deformity, loss of function, or complete inability to move the shoulder joint, point tenderness, ecchymosis, and swelling. When we have somebody with a fracture, we need to treat them immediately. We need them to remain still and calm, sit them in a comfortable position, and have them not move the arm. We can also call 911 or have someone else call 911 for you so the athlete can be transported to the ER. During this time, we can splint the arm using a sling, and we can also apply an elastic bandage to make the arm immovable or to add some support. If needed, we also need to treat for shock, and we could also possibly use an ice bag to reduce any pain. After sustaining and going through the initial treatment or the emergent treatment, most times clavicle fractures, individuals will wear a figure 8 brace that's shown in the book, and this helps to realign the clavicle in place. This is typically worn for about 3 to 8 weeks. For humeral fractures, the physician will have the athlete wear a sling for approximately 4 weeks before range of motion and any other rehabilitation can occur. Very rarely does surgery occur. For prevention, we want individuals to wear appropriately fitted shoulder pads, and we want to teach them how to fall correctly or properly. Most times we see falling in areas such as volleyball, and they have been taught how to fall and roll so they don't have these types of fracture injuries. In addition, we can also instruct athletes to have good supply of calcium and vitamin D and perform weight-bearing activities to keep their bones strong. Dislocations and subluxations can also occur at the glenohumeral joint. These are very similar because these injuries both involve displacement of the humeral head from its normal position in the joint relative to the glenoid fossa. With dislocated injuries, we look at injuries where the humeral head moves out of the normal alignment and remains in that position. A subluxation is when the humeral head moves out of normal alignment and then spontaneously reduces back into normal alignment. These can occur in anterior, inferior, and posterior manners, with the anterior dislocation being the most common. Once an individual has sustained a dislocation or subluxation, it stretches out the ligaments and the musculature around, which causes the likelihood of sustaining another dislocation or subluxation to increase. After dislocation or subluxation, these are permanently stretched areas, and we need to use the musculature around to help support the shoulder more, or in some cases have surgery. When we look at mechanisms, again, we see dislocations and subluxations from falling on an outstretched arm. An anterior dislocation can also occur when a direct blow occurs to the arm when the upper arm is abducted from the body and the elbow is at a 90-degree angle. Inferior dislocations can be caused by a direct blow down onto the tip of the shoulder while the arm is at the athlete's side, while a posterior dislocation can occur when the arm is outstretched and the athlete falls forward, which forces the head of the humerus backwards. Signs and symptoms are very similar between a subluxation and a dislocation. A dislocation appears physically deformed. This is one of the biggest differences between a subluxation and dislocation because a dislocation remains out of alignment compared to a subluxation spontaneously going back into place. The athlete can also complain of severe pain, inability to move the arm, point tenderness, loss of feeling into the hand due to trauma of the brachial plexus, as well as malalignment, swelling, and ecchymosis. Sometimes the individual may also go into shock with dislocations. Subluxations are very similar, but remember there is no obvious deformity because it spontaneously goes back into place. When we look at treatment, we need to have the athlete stop activity and rest in a comfortable position while we call 911. What we don't want to do, we don't want to relocate any dislocations that the athlete may have. We can splint the arm in the position that we find it, apply ice to the area, and treat the person for shock, but we don't want to put that arm or the shoulder back into place. For prevention, we need to make sure that the athlete has an adequate muscular mass and strength, as well as flexibility, including active range of motion and passive range of motion. We also need to make sure that they are wearing proper protective gear and that they're aware of their surroundings when they are at practice or competition or whatever that they are doing. When we look at a shoulder separation, this is a little different than dislocation or subluxation, but this occurs when we disrupt the AC joint or the acromioclavicular joint, which is really the point of the shoulder when you look at the shoulder. The ligaments around the joint are stretched, creating a joint sprain. Like sprains we talked about before, the AC joint can be sprained at grade 1, 2, or 3 levels. The higher grade of separation requires greater rehabilitation and possibly surgery in order to maintain and to get back complete shoulder function. Typical mechanisms include a fall on an outstretched arm or a direct blow to the tip of the shoulder, AC joint, or clavicle. We see signs and symptoms including discomfort to significant pain depending on the degree or grade of injury. Deformity, and the deformity increases with the grade of injury. Usually with a grade 3, we do see some deformity, and weak shoulder musculature. For treatment, what we want to do immediately is apply ice and decrease as much pain as possible, and then use a sling to rest the area and then refer to a physician. Depending on the grade of the shoulder separation or the AC separation, it depends on how long it will take to heal. The greater the degree, the longer the healing process. Sometimes with grade 3 separations, we can wear a specialized immobilization brace that supports and rests the arm for a longer period of time, as well as taking NSAIDs to decrease pain and inflammation, and then rehabilitation along with that rest and ice. To prevent, we want to know or we want to pay attention to body position and proximity to others. equipment and the likelihood of avoiding an AC separation. We want to wear protective padding and make sure that the upper extremity has full range of motion or significant range of motion and muscular strength. Sprains in the shoulder area can also occur at the AC joint, the sternoclavicular joint, and the glenohumeral joint, but sprains to the sternoclavicular joint are not as common as the AC joint and the GH joint. A sprain to the sternoclavicular joint typically occurs due to a direct blow to the sternum or at the end of the clavicle. Sprains to the sternoclavicular and glenohumeral joint can be occurred due to a fallen outstretched arm or a blow to the tip of the shoulder. Same thing as what we've seen before with other injuries. A glenohumeral joint sprain can also be caused by a sudden movement that stretches the joint ligaments too far. Signs and symptoms include point tenderness and pain. The person will not be able to move the shoulder through the full range of motion without pain. There may be some swelling present as well as deformity, especially at a larger grade, specifically grade 3 sprains. This is what you can see. We can see the normal shoulder in the back picture there, and then type 1, type 2, and type 3. We can see as we go up in type that those ligaments are stretched more, specifically in type 3 or grade 3 types of sprains, that ligament is completely torn away in the middle there. Treatment for a sprain, we want to make sure we immediately apply RICE, so we rest, ice, compress, and elevate. If there is a grade 2 or grade 3 sprain, it's suspected we want to splint the arm to prevent any movement, continue on with that rest and ice, and then refer the athlete to a physician. Just make sure that they're checked out in case there are any other additional injuries. Prevention. Before this even occurs, we want to make sure they have proper form, proper body mechanics during their skills, and upper body conditioning. Glenohumeral joint instability. This is where we have excessive movement in the glenohumeral joint, and really it's weak all over, and it can be classified as anterior, posterior, or inferior, similar to what we see with our dislocations. Most often, athletes, though, have multidirectional instability, where it's instability in various directions. Typically, an athlete, though, if there is some sort of instability, it is solely inferior instability. When we look at mechanisms of injury for glenohumeral joint instability, it can be caused by a traumatic event, or it can result over a period of time. Typically in athletics, we see that over time occurs more often where the ligaments are stretched and or the capsule surrounding the joint is stretched, and this results in significant laxity or looseness of the soft tissue structures around the joints, and this laxity then causes this instability. Signs and symptoms include joint laxity, clicking, popping, crepitus, which is a grinding type of sensation, pain within the area, and decreased active range of motion due to joint pain and muscular impingement. Treatment, we want to make sure that we have the athlete stop activity, use the RICE principle, apply an ice pack, and then refer the athlete to the physician for an evaluation to see if there's anything else going on within the joint capsule. Prevention, similar to other injuries, specifically the glenohumeral dislocations, subluxations, and sprains, we want to make sure that the musculature is strong and that we are conditioned well. For muscle strains in the area, these typically occur to the biceps brachii and triceps brachii and rotator cuff musculature, with the biceps brachii being the most commonly ruptured. As with other strains around the body, shoulder strains are caused by a forceful concentric or eccentric muscle contraction. A strain can also be caused by a passive muscular stretch. And most often when we look at biceps brachii and rotator cuff muscle strains, they occur in overhead types of activities such as throwing and repetitive swimming motions. Typically, muscles are strained during the eccentric contractions that occur during the follow-through phase, where the muscles are slowing down or trying to contract to slow down that rapid arm movement. Signs and symptoms, we have pain with active range of motion. It occurs with active range of motion because strains occur within the musculature. We may have a dull, achy feeling at rest, weak musculature, and point tender in some areas of the muscles. We can see here in this picture, this is a pectoralis major strain, where you can see that divot that occurs if it is a grade 3 strain that is not attached anymore, and it kind of divots because it's balled up within the muscle belly. For treatment, it's a little different between the grades, but grade 1, we want to continue to ice and rest and eliminate any activity that causes the athlete pain or recurring of symptoms. Grade 3, we want to make sure that we call 911, treat for shock, depending on if the athlete's in shock or not, and then refer to a physician for any strain that causes muscular weakness, loss of function, moderate pain, and neurological symptoms including tingling, numbness within the arm or hand, because there can be something more going on than just a muscle strain in that situation. For prevention, we want to make sure that we have adequate muscle flexibility and strength and perform our skills properly. Next, we have impingement syndrome. Impingement syndrome occurs most often with the supraspinatus tendon and the long head of the biceps brachii tendon. When we look at the mechanisms, these are really caused by overuse injuries and overhead throwing, where we continue to use the same musculature and complete the same motions over and over again in a repetitive manner. But they can also be caused by direct trauma to the area, muscular imbalance between the front side or the anterior aspect of the shoulder, where there's the deltoid and the biceps, compared to the posterior aspect where we have the rotator cuff musculature. There may be rotator cuff muscular weakness and a whole slew of things within there, but the ones that I mentioned are the main mechanisms of injury that we see with impingement syndrome. We can see here in this picture on the left-hand side, this is what is normally occurs. So blue meaning good. We have the bursa within the glenohumeral joint, and we can see the supraspinatus tendon coming in on the left-hand side, as well as on the right-hand side. That is the biceps brachii tendon coming up on the humerus there. But when it becomes impinged, we can see that bursa is providing no more lubrication, and that the head actually of the humerus digs into the glenoid fossa and into the glenohumeral joint and really impinges the subacromial space where that supraspinatus tendon is, and it causes that friction to occur over and over again with overhead activities, and actually can start to see fraying and tearing of that tendon within the glenohumeral joint. This can also occur with the biceps brachii on that lateral side, on that right-hand side picture. Signs and symptoms include inflammation, pain, inability to raise the arm into a cocked position or overhead position, abducted position, externally rotated position, because this pain is too great and there's muscle weakness that occurs. We want to make sure that we stop all upper extremity activities, all throwing motions with the affected arm, apply our Rice principle, and refer to a physician for evaluation. When we look at preventing some sort of impingement syndrome, we want to make sure that the athlete listens to their body to prevent this type of injury. If they're feeling any discomfort, we should stop the activity immediately and apply ice and refrain from those activities so that we can kind of quiet down the area so we don't cause further injury. Next, something similar is tendinitis. Tendinitis typically occurs at the rotator cuff and biceps brachii muscles, and this is when these tendons are inflamed, and they can become inflamed acutely or chronically. but most often tendonitis occurs in these muscles in a chronic condition because the same repetitive motions occur over and over again over a long duration. Mechanisms, we can see repetitive, low-intensity contractions, typically through throwing or overhead motions, but it could also be from a violent muscle contraction, acute trauma, or poor body position where we're stuck in a position over a period of time. Signs and symptoms include pain, crepitus, point tenderness, loss of function, and tendon thickening that can exist. Treatment again is RICE, and then if it continues to bother the individual, we can refer to a physician where they can prescribe NSAIDs, rest, and rehabilitation for the individual. Prevention, again, we want to make sure that the area around the shoulder is strong, that we strengthen the opposing muscles similarly, and that they're of equal strength. Avoid overhead activities, listen to our body, and rest shoulders after strenuous activity and at periods after long bouts of activity. A muscle contusion or an upper extremity contusion typically occurs from a direct blow to the muscle, usually by a body part or an implement. This is a contusion that we typically see across the body in any parts of the body. We have pain. We can see ecchymosis, swelling, tingling, point tenderness within the area. Treatment, we want to RICE, we want to rest, apply ice, compression to the area to decrease that swelling and inflammation. If there's still pain that persists, we can splint the arm in a sling and refer to the physician for evaluation. Sometimes, depending on the mechanism, how forceful it is, we may suspect a fracture. If that is suspected, then we need to summon EMS as quickly as possible. With a contusion, if it does happen over and over again, there may be an injury called myositis ossificans within the biceps tendon or the biceps musculature, and that is from repetitive contusion, repetitive blows to the biceps over and over again. And really what occurs is that calcium forms from this pressure over and over again, or this trauma over and over again within the muscle. And when this occurs, an individual cannot get a full contraction, and sometimes they have to go in for surgery and scrape out this calcium formation within the muscle so that the muscle can go through the full range of motion. Brachial plexus stretch injuries occur in the brachial plexus, which is a pathway of nerves located in the neck and shoulder region on both sides of the body. Typically, if we hear somebody say, "Oh, I got a stinger or a burner," that's what they refer to as a brachial plexus stretch in layman's terms. These injuries typically occur in contact sports. Football is very common. Wrestling is very common as well. But when we look at mechanisms, a brachial plexus stretch injury occurs when the shoulder is depressed and the neck is either rotated away or tilted laterally from the depressed shoulder. So we're really stretching out those nerves within the shoulder. Signs and symptoms typically include burning, tingling, and numbness down the arms and fingers of the affected side. And what we can do to make sure that there's no further head or spine injury, this is a one-sided injury where we only have numbness tingling on one side of the body. Now, if we do have numbness tingling down both sides of the body, this could indicate a further injury of the head, neck, or spine. For treatment, we want to make sure that we increase range of motion activities to the extremity. First we want to rest, and then we can increase range of motion and regain range of motion and strength once sensation is back in the hand and upper extremity. If the symptoms happen to not subside within a couple of days or quickly, we should refer the athlete to a physician just to make sure anything else isn't going on within the shoulder area. For preventing, it's really difficult to prevent, but we need to make sure that we have have daily neck range of motion activities, flexibility and strengthening exercises, and make sure that we're tackling properly and using proper form for all activities that we are in. As you will see within this aspect of the chapter, I did not talk about thoracic outlet syndrome, adhesive capsulitis. These are injuries that you can read on your own within the chapter that I'm not going to go into, so make sure that you read over these two injuries because they can appear in your quizzes for this learning module.